University of Liverpool in the United Kingdom, and it's a great honour and pleasure to speak on CC to ABC, covering atrial fibrillation characterization and holistic integrated care as part of the 2020 European Society of Cardiology guidelines on atrial fibrillation. This slide summarizes my declarations of interest. I'm not going to read every line, but put into context everything I say or speak with this presentation. We now recognize from textbooks the steps for risk assessment and management of patients with atrial fibrillation, and all textbooks would cover points like stroke prevention, management of symptoms with regard to rate control or rhythm control of patients with atrial fibrillation, and also focusing on cardiovascular risk factors and associated comorbidities. And this is the so-called patient pathway, integrating care, holistic care for managing patients with atrial fibrillation. And given that atrial fibrillation is so common, we need real-world managing which requires simple and practical decision-making processes. And before the patient pathway is started, we need to improve our detection and awareness of atrial fibrillation. And this is covered in the new guidelines from CC to ABC. So what is the CC? The first C is to confirm atrial fibrillation, and this covers confirmation of the diagnosis, awareness, screening, and detection. We have the C for characterized atrial fibrillation. This refers to the 4S concept, and the 4S is for stroke risk. Then we have symptom severity, and we have the severity of atrial fibrillation burden, and then substrate severity. And from the CC of confirm AF and characterize AF, this leads to the ABC pathway. What is A? A is avoid stroke, and A is anticoagulation, where the default is to offer stroke prevention unless they're low risk. The B is better symptom management or better symptom control. And the C is the comorbidity and cardiovascular risk factor management, including lifestyle changes. Easy as ABC. So with regard to the recommendations for structured characterization of atrial fibrillation, the first of the recommendations states as follows. Structured characterization includes clinical assessment of stroke risk, symptom status, AF burden, and evaluation of substrate. And all this would inform treatment decision making and facilitate the optimal management of AF patients. The 4S scheme covers the aspects of AF management as follows. With stroke risk, you have the CHADS-VAS score. With regard to symptom severity, you have the ERA symptom score, which also deals with quality of life. Severity of AF burden will refer to the temporal pattern of atrial fibrillation as well as the total arrhythmia burden. And finally, the substrate severity, you can assess as from clinical assessment and of course increasingly cardiac imaging. So with regard to the holistic and integrated approach to managing atrial fibrillation, I'll now cover stroke prevention. And this is the A. A is for avoid stroke, or A is for anticoagulation. And before you even consider the anticoagulation treatment, you have to assess risk. And for stroke risk assessment, the message is keep it simple, keep it practical, because risk scores are simplifications to aid decision making. And all the published clinical risk scores have modest predictive value for identifying the high-risk patients. You can, of course, have more complicated risk scores. You can add multiple biomarkers. They may well marginally only improve on prediction. And do remember, statistical significance is not the same as clinical significance, which needs to be balanced with practical application in busy wards, busy clinics that you and I do. Risk is also dynamic. It is not a static process, and therefore stroke risk assessment should focus on the risk factors rather than artificially categorizing them into low and moderate and high risk strata, because that's very artificial. There's numerous stroke risk factors in the literature. The more common and the more validated ones have been used to define risk scores, and the one used in the ESC guidelines is the CHADS-VAS score, and the acronym is defined on this slide. Now, just to illustrate what I mean by a risk score being a simplification, let's focus on age. We know that age is a powerful driver of stroke risk, and stroke risk is of course a continuum, as is age. But age 65 to 74 gets 1 point, then 75 and above gets 2 points. But it's only common sense that a man with atrial fibrillation age 65 is going to be at lower risk than a man with atrial fibrillation age 74. A 74-year-old man who and 11 months old, 74 years old and 11 months, who comes to the clinic, gets 1 point. They come back 4 weeks later, become 75, they get 2 points. It does not mean that their stroke risk suddenly doubles. Finally, for sex category, female sex. This is a risk modifier rather than a risk factor, because being female and age over 65 or one or more stroke risk factors, being female adds to the risk. And it's important to keep this in the CHA2DS2-VASc score, as neglecting that would underestimate stroke risk in female AF patients. To illustrate now that how risk is a dynamic process, this is a study that looks at comorbidities, incident comorbidities in those initially at low risk with a CHA2DS2-VASc score 0 in males or 1 in females. And as the Kaplan-Meier curves show, the accumulation of those individual different risk factors, and each of the individual components of the CHA2DS2-VASc score does changes at different rates. For example, the steepest gradient is for hypertension, followed by age over 65, then heart failure, then diabetes and vascular disease. And in 80% of the patients who acquired one or more comorbidities, the new condition occurred after approximately 4 months of the diagnosis of atrial fibrillation. Conversely, the time from incident comorbidities to the presentation with an acute ischemic stroke was approximately 4 months for about 90% of those patients sustaining an ischemic stroke. Hence, for the A criteria, let's keep it simple. Default is stroke prevention unless they're low risk, given the limitations of all the risk scores. And stroke prevention means oral anticoagulation, whether with well-managed warfarin or, ideally, a NOAC. And that's reflected in the recommendations in the ESC guidelines. The Class 1 recommendations are shown on this slide. As you can see, the first refers to NOACs being the preferred anticoagulant choice. For stroke risk assessment, a risk factor-based approach is recommended, initially identifying the low-risk patients, that's a CHA2DS2-VASc score 0 in men and 1 in women, who should not be offered antithrombotic therapy. For patients with 2 or more stroke risk factors, CHA2DS2-VASc score 2 in men or 3 in women, is a Class 1 recommendation for oral anticoagulation. For those with a single stroke risk factor, CHA2DS2-VASc score 1 in men or 2 in women, anticoagulation should be considered, and that's a Class 2A recommendation. And this is reflecting again the level of evidence and the support from clinical trials for those different recommendations. We then have the bleeding risk assessment here, where a formal structured risk score-based bleeding risk assessment is recommended. And this is to identify the modifiable bleeding risk factors and to identify the high-risk patients for bleeding that should be scheduled for early and more frequent review. And that's a Class 1 recommendation, with the HAS-BLED score as the best validated score with a Class 2A recommendation. But do use bleeding risk assessment appropriately and responsibly. This is evidence-based. I show here a PCORI independent systematic review and evidence appraisal. This is evidence-based guidance. This is not eminence-based. This is not VIP-based. The systematic review concludes the HAS-BLED score provides the best prediction for bleeding risk. And the focus, as to re-emphasize, is to address the modifiable bleeding risk factors and to flag up the patients at high risk for early review and follow-up, and bleeding risk is also highly dynamic. High bleeding risk score is not an excuse to give a whole anticoagulant therapy. Now, subsequent recommendations are summarized on this in the next couple of slides. Risk assessment is dynamic. You therefore need to reassess risks. Those initially at low risk of stroke, you need to reassess risk maybe about 4 to 6 months afterwards. If you're using a vitamin K antagonist, aim for a TTR above 70%. Those with a low TTR, well, you either switch to a NOAC and make sure that good adherence and persistence with therapy, or otherwise improve your efforts to improve the TTR. There are 3 class 3 recommendations. In other words, do not do this. For example, antiplatelet therapy alone is not recommended for stroke prevention in AF. Bleeding risk assessment is not itself to guide treatment decisions. And the clinical pattern of AF should not condition the indication to thromboprophylaxis. There are a couple of recommendations with regard to left atrial appendage occlusion. And this essentially is for patients with very clear and absolute contraindications for long-term anticoagulant treatment. And you can certainly consider this also for surgical exclusion of the left atrial appendage. The algorithm for stroke prevention is highlighted on this slide. And this sums up some of the recommendations I've shown earlier. You'll see the first step is to initially identify the low-risk patients where no antithrombotic therapy is recommended. Step 2 is to offer stroke prevention to those with 1 or more stroke risk factors. In those with 2 or more stroke risk factors, there's a strong recommendation with a class 1 recommendation for oral anticoagulant therapy. And for those with a single stroke risk factor, anticoagulation should be considered with a class 2A recommendation. And step 3 is to make your choice for anticoagulations, ideally with a NOAC. Subsequent presentations in this session will cover the B and the C of the ABC, management of atrial fibrillation, easy as ABC. So let's put this all together, a holistic approach to risk assessment and management of patients with atrial fibrillation. We do know that atrial fibrillation is so common, so they will present to general practitioners, very often asymptomatically. They may present to the emergency room. In the hospital, they may present to non-cardiologists. They may present to cardiologists. And the central to all this is the patient. And our patients need a simple and streamlined and uniform practical approach to their care and management, whether they get the information from the GP, the emergency room doctor, the non-cardiologist, or the cardiologist. Something simple and practical that is uniform across the patient journey, across the patient pathway. And that's summarized on this slide. And that is the ABC pathway, because it's what I covered in this presentation. The A, avoid stroke, and that's the default is stroke prevention unless they're low risk. What is the B? Better symptom management, patient-centered and symptom-directed decisions on rate or rhythm control. And the C, addressing cardiovascular and comorbidity risk factors, as well as lifestyle changes, as well as the patient psychological morbidity. The ABC pathway for integrated management offers a simple strategy that streamlines the primary and secondary care of patients with atrial fibrillation. And superimposing the figure from the previous slide, you will see here how we can have a uniform approach to managing atrial fibrillation, whether it's from the primary care perspective, whether it's from the secondary care perspective, whether it's from non-cardiologist perspective or the cardiologist perspective, and the patient central to all this gets a uniform and simple approach from all the stakeholders, simple, as easy as ABC. A, avoid stroke, B, better symptom management, C, comorbidity, and cardiovascular risk factor optimization. A simple strategy streamlining the care of patients with atrial fibrillation. Thank you for your attention.